Hello, my name is Amanda Woehrle, and this is my DMP project on sub-epidermal moisture scores and heel offloading interventions. A pressure injury is damage to the skin or deeper tissue due to both pressure and shearing. When they occur in the hospital, they are considered a never event and should not have occurred. These injuries can lead to an increased risk of infection, sepsis, amputation, and an increased mortality for patients. According to the National Pressure Injury Advisory Panel, there are over 2.5 million reported pressure injuries that occur each year, and up to 60,000 deaths that are contributed to pressure injuries. The most vulnerable are the elderly population as well as the critically ill population. The average treatment cost is $11,000 for the patient. However, there are other financial implications, such as insurance companies denying payment for their stay if they received a hospital-acquired pressure injury. The Braden scale is often used in the hospital setting to assess for the risk of pressure injuries, as well as what corresponding interventions should be applied. However, there is a tool called the Sub-Epidermal Moisture or SEM device that can be used to assess the risk of a pressure injury prior to any tissue changes that can be visually seen. The implementation of this SEM device is another tool to help prevent pressure injuries from occurring, as well as help the bedside nurses implement interventions based on the SEM score and their risk of tissue damage. Visualization and palpation is also used to detect early skin changes, but can be even more challenging with varying skin tones, especially darker skin tones. With darker skin tones, it may be difficult to assess the stage of the pressure injury or even see deep tissue pressure injuries. And it may only be noticed by the clinician when the injury has progressed and it has become an open ulceration. With the SEM scanner, the clinician is able to detect micro changes in the subepidermal moisture of the tissue. Even with the evidence showing the SEM device can detect this tissue damage sooner, interventions are still needed to stop or reverse this damage. This is where nursing interventions for the patients within the hospital setting can be implemented. When using this SEM device, nursing interventions can be increased if the SEM score is increasing, or if they're using one intervention, they can switch to another one if what they are using is not correctly offloading them. The nurses still need to address risk factors for each patient and implement these interventions. This project's aim was to determine if there was any difference between heel boots or pillows for offloading heels using the SEM scanner and the Delta scores to determine which intervention was more indicated for offloading. According to a study done, there is a potential to detect pressure injuries and tissue damage up to 3 to 5 days earlier than visual inspection using the SEM device. There's an increased local edema that may be present that cannot be visualized or palpated, but it can be captured by the changes in the scanning device reading. Even with evidence showing that the SEM scan device can detect the tissue damage sooner, interventions are still needed to stop or reverse the damage. This goes back to those nursing interventions for patients in the hospital. With pressure injuries forming in a patient in as little as 2 hours and nursing only relying on visualization to detect these injuries, prevention is harder if the damage cannot be visualized until it's already occurred. In patients, again, with a darker skin tone, just visualization of the tissue can pose an even larger challenge and a delay in recognizing pressure injury development. A study conducted in a facility with a significant portion of darker skin tone patients showed that the pre-implementation group had almost 9% pressure injury incidence, and the implementation group had 0 pressure injuries. This was a 100% reduction in pressure injuries with the implementation of the SEM device to help recognize tissue damage in individuals with darker skin tones. In a before and after study that was conducted in Spain, it was determined to see if a risk stratification intervention bundle taught to the nurses in the ICU would decrease pressure injuries on that unit. The before phase included standard interventions to prevent pressure injuries, while the after phase was the new risk stratification Modified Intervention Bundle. The pressure injuries were reduced in the after phase, going from 3.9 to 2.1%, indicating a 46% reduction in pressure injuries. The purpose of this DMP scholarly project was to determine if there was any significant difference between the heel boots and pillows for offloading of heels and pressure injury prevention in the adult ICU settings, and also to determine the effectiveness of the offloading device using the Sub-Epidermal Moisture Scanner, or the SEM scanner. It was a quality improvement project to improve the process within the adult ICU in regards to pressure injury prevention, as well as consistent use of the SEM scanning device to detect early tissue changes. This project was driven by a retrospective chart review. Quantitative data was collected from the electronic health record on both SEM scores for the heels as well as the nursing intervention, such as either pillow elevation or the heel boots. The current practice for offloading heels is determined by the bedside nurse, and there is no protocol on which intervention for heel offloading should be used when. Results of this project will be evaluated to determine if one nursing intervention over the other helps to reduce the SEM delta scores, thereby theoretically decreasing pressure injuries. The subjects in this project were any adult patients admitted to either of the facility's 2 intensive care units. There are 32 beds on each unit, so potentially 64 patients every day getting scanned. Every day, the bedside nursing staff would scan the heels with the SEM scanner and record it in the electronic medical record. Race, age, or gender did not make a patient disqualified to be scanned. The only exclusions were if the patient refused, if they had had an amputation on one or both limbs, existing wounds to either of the heels, or any non-removable devices, such as hard casts or orthopedic braces, with orders not to remove. The SEM device was a brand new technology launched in the ICUs at the facility 3 months prior to this project. Extensive education was provided to the bedside nurses on how to use the SEM device, along with evidence-based practice on how it can reduce pressure injuries by detecting the tissue damage earlier. Staff were educated on where to record the Delta SEM readings, as well as the pressure injury prevention performed. Management and the wound care team, along with reps from the company, were rounding in the ICU units when the product was first launched. Management and the wound care team were also available to address any questions after the company's reps left during that first 2-week period when it was first launched. Management would check the charts daily to see if the SEM scanning was completed on overnights. If it was not, a message was sent to the day shift nurse to complete this with their bath cares. The data collection tool was created in Excel to include the sub-epidermal moisture scores, as well as each heel intervention for offloading. The 2 columns in Excel, there were 2 columns in Excel. One had the SEM data point, and one had the interventions, and it was either heel boots or pillow. Patients that only had one heel that could be scanned due to amputation, wounds, or non-removable medical devices were still included for the one heel that was scanned. The collection data was only used if the patient had 3 or more SEM data points to compare over 3+ days. If other interventions were listed, these data points were not included. Other interventions could be a severe ankle pillow or a bordered foam dressing, which is considered an intervention in the medical record. So 235 heels were scanned over a 2-month period. The SEM delta score was recorded. The heel boots had a mean of negative 0.39 and the pillows was negative 0.27, and that was the delta score between day 1 to day 3+, depending on how long the patient was there. The data points collected for the subepidermal moisture delta scores in heels was analyzed using the Mann-Whitney test. This test was done to determine if there was any statistical difference in the subepidermal moisture delta scores between using heel boots or pillows for offloading pressure to the heels. The p-values were two-tailed in the Mann-Whitney test. A test of normality was also completed. The results indicated that heel boot scores significantly deviated from a normal distribution. The Shapiro-Wilk had a P of 0.044. The offloading of the heels with pillow scores did not significantly deviate from normality, with the P being 0.319. Based on these findings, the assumption of the normality was violated for only the heel boots, but was met for offloading of the heels with pillows. The mean rank scores were 113.24 for the heel boot group and 120.90 for the pillow group, indicating only minimal differences between the groups. The Mann-Whitney U-test indicated that there was no statistical significant difference in the delta SEM score between heel boots and pillows, with the P being 0.400. Since the sample size was 235 heels scanned, it was a relatively large group to be able to run these tests and show the data. So one limitation that came up during the project was that some of the nursing staff refused to complete the SEM scan on patients. It was a relatively new device when this project started, and a lot of staff did not want to add another task and charting to the things that they were already doing. The task was to be completed on the night shift with the patient's bath cares. If this wasn't done, it was not immediately evident to the daytime supervisors, as they came in after the night shift nurses had already left. The supervisors started daily audits of the charts and asked the daytime nurses to then complete the task if it wasn't done. This did create some animosity between staff and supervisors, as well as between the two different shifts. So since it was relatively new, there was a little pushback from staff about adding to the workload, like I had mentioned, and then this did lead to inconsistent heel scanning and low compliance. During the time that this device came out, it was also union negotiations for the hospital, which I believe also led to some of the non-compliance, as staff and management were already engaging in negotiations, which can become a pretty tense time for the floor staff as well. At this time, there are no changes to the organization policy for pressure injury prevention, as there was no statistical significance between the two offloading interventions. The pressure injury prevention orders currently state to offload heels. There is no indication of which intervention to choose, and no policy changes were made based on these findings, thereby giving nursing staff the autonomy to decide which intervention to use. Poor compliance may have been a factor in the data, showing no statistical difference between these two interventions. Currently, the project and the SEM scanner is only being used in the ICU. If there was significant reduction in pressure injuries over time, this device could then be used throughout the entire hospital system to help prevent pressure injuries in other areas. Nursing staff at the bedside are responsible for pressure injury prevention interventions for their patients. The Braden scale is often used in the hospital setting to assess the risk of pressure injuries, and what corresponding interventions should be applied. However, the SEM device can be used to help assess that risk factor as well, and if there's any changes in the tissue while the patient is there. The implementation of the SEM device is another tool to help prevent these pressure injuries and to help the bedside nurses implement their interventions. The quality of nursing care to our patients may improve if they can see the link between the trending SEM score going up, which indicates damage to the tissue, as well as what their pressure injury interventions are doing to move that score up or down. This project was conducted over 2 months with daily scans of the heel. The SEM delta number, along with the pressure injury prevention intervention, was collected and entered into Excel. Analysis of the data showed there was no statistical significance of the delta SEM scores between the heel boots and pillows for pressure injury prevention. The project's findings showed that the use of either the heel boots or the pillows remain appropriate for effective pressure injury prevention for offloading of the heels. With the SEM device being a very new tool to our 2 ICUs, one recommendation that I do have for our facility would be to repeat this study again at the 1-year mark of implementation. There was low compliance, which could have led to no statistical significance between the 2 interventions. As the scanning of heels is more widely accepted and completed, these results could change. This may inform future policy changes in pressure injury prevention and increase the quality of care given to our patients. The scanning device is also used on the sacrum, so if there is a reduction in heels, we could also potentially see a reduction in our sacral injuries, which tend to be a lot more severe for our patients. This DNP program has been extremely challenging, but also very rewarding. These last 3 years have gone by what seems like very, very quickly. I continue to expand my knowledge each semester as I grow, and I can see myself changing throughout my clinicals and feeling more confident with each semester. I have been very grateful to have this opportunity to further my knowledge and education to hopefully help bring more awareness to pressure injuries and wound care at my facility, to have a higher level of care that I'm able to provide to my patients. Thank you. Here are my references for this presentation. Thank you.